everybody. Today we'll discuss about proteinuria. We see a lot of cases in our day-to-day basis who are having proteinuria. We routinely send protein creatinine ratio on our in our IP and OP cases. There are many causes of proteinuria, but before sending a proteinuria, if you're evaluating for proteinuria, always check if there is underlying urinary tract infection or some kind of sepsis like infection is going on. Patient is going to some stress or inflammatory or whatever, some dengue fever or some viral fever, because they can cause stress proteinuria also. So you should always rule out the physiological causes like any exercise, any menstruation, any UTI, any infection, ongoing infection, any ongoing inflammation, or any recent procedure. They can all cause proteinuria. So always remember all of these causes before labeling it, some evaluating for pathologically. So this is one possibility. And before we will go ahead and discuss few cases, and based on that we'll understand better about proteinuria. So a 25-year-old male presented to OPD with complaints of edema of limbs and frothing of urine. So there's a 25-year-old male presented to OPD with the complaints of edema and also frothing of urine. So from this we will understand there is frothing of urine suggests proteinuria. That is how they discovered protein in the urine. And edema of lip, the patient present with complaints of mostly this is a nephrotic syndrome like presentation where the patient have hypoalbuminemia, edema, and also there is proteinuria. So there's a triad of nephrotic syndrome, whereas nephritic syndrome generally present with hematuria, hypertension, and proteinuria, nephritic range proteinuria. So there are few causes of nephrotic. This is classical case of nephrotic syndrome. So before evaluating, you understand this is a case of nephrotic syndrome. You quantify the protein. Generally, urine protein more than 3.5 gram in 24 hours, or urine albumin creatinine more than 2.2 grams is suggestive of nephrotic range proteinuria. So before evaluating this case, we need to understand what are the causes of nephrotic range proteinuria. So we need to understand what are the causes. We understand one is minimal change disease, especially in the children we see nephrotic range proteinuria, and also you see it in membranous nephropathy, especially in the elderly, where you find with membranous nephropathy in elderly 50 years and 60 years, and between 20 to 40 years you might find FSG is a common cause of nephrotic range proteinuria. Other causes of nephrotic range proteinuria are amyloidosis, diabetes related, and some case of Fabry disease. They all can present with nephrotic range proteinuria. So whether the cause is MCD, minimal change disease, or FSGS, or some membranous nephropathy, you need to evaluate based on the age. First thing, generally minimal change disease is generally seen in children, less than 14-15-year-old children. Generally in them you directly go ahead and start with steroids. They generally remit. Sometimes the relapses are common, but especially in the case of 20s and 40s, especially adolescent age and 20s, the most common cause of nephrotic syndrome is focal segmental glomerular sclerosis. That can be primary or secondary, that is next thing, but this FSG is the common cause. In the more than 50s and 60s, where the common cause is membranous nephropathy, they can present with renal vein thrombus because of the hypoalbuminemia. They are prothrombotic. They can directly present with renal vein thrombus, also some flank pain, and also renal vein thrombus is a common presentation in them. So that can be a presentation in them. So especially in elderly, if there is nephrotic range protein, the membranous nephropathy is one thing. And sometimes in elderly, if it's some underlying diabetes or some amyloidosis, so you can present with nephrotic range proteinuria also. Generally the kidneys are large in them. In all of these countries, generally kidneys are shrunken, especially in the case of diabetes, amyloidosis, and HIV associated nephropathy. They generally have kidneys are large. So they can also present with nephrotic range proteinuria. They are all the cause of nephrotic range proteinuria. In this case, since 20 years old, first thing we think is FSGS. So we go ahead and do the biopsy. We'll find FSGS. It might be a case of primary, since primary FSGS is the one which presents nephrotic syndrome, whereas secondary is something related to sickle cell or single kidney or some obesity or some any VU or vascular vesicular reflex, some secondary cause. They don't present with nephrotic syndrome per se, they only present nephrotic range proteinuria. But this presented with nephrotic syndrome, it might be a case of primary FSGS. We go ahead and do biopsy where we find immune staining with IgM and C3. So IgM and C3, you find it primary FSGS is a possibility. So but in this case what we found is we found electron microscope, no immune complexes are found, and we found minimal change disease pathology. So what is the cause of minimal change disease pathology? We evaluated what is the cause in adult present with minimal change disease pathology. So we got a CT chest done where we found lymph nodes. We got a biopsy done. It's a Hodgkin's lymphoma. So minimal change disease also can present at adolescents where there is some secondary pathology like that can be allergy, atopic dermatitis, some bronchial asthma, or some drug, NSAIDs or interferons. There are many drugs that can cause penicillamine, and some tumors like Hodgkin's lymphoma, CLL, mycosis fungoides. In this case, Hodgkin's lymphoma is a cause. So always minimal changes can be secondary to something else like some allergy pathology or some NSAIDs, some tumors like Hodgkin's or CLL or mycosis. So this is a case of Hodgkin's related MCD, minimal changes present with proteinuria. We treated the primary condition, it resolved. A 30-year-old male who regularly goes to gym, an evaluation found to have proteinuria. So this is one more thing. Exercise itself can cause proteinuria due to exercise-related proteinuria. So it is common. So you need not go ahead and evaluate. So ask them to stop exercise for a few days and re-evaluate for proteinuria. If it is normal, you need not evaluate. So always this might be exercise-related proteinuria. Always load the physiological conditions before labeling, evaluating for pathological conditions. A 26-year-old female history of joint pains, fever, and was admitted on evaluation has proteinuria of 420 milligrams on 24 urinary protein. So this patient has fever and joint pain. So she has some CTD history. So she has some autoimmune condition, especially fever and joint pains. We go ahead and think some viral pathology is also a possibility. First, to always think of viral if it is an acute condition. If she is having fever and joint pain for long term, like more than 6 weeks or something, the chronically she is having fever. That is also classical inflammatory small joint pains are there, and some skin manifestations like malar rash. Where malar rash, you'll have classical pinkish rash where the nasolabial sparing is there, if it is there, and also some pleuritis is there. If you have other slick features, other SLE related or CTD related features are there. With proteinuria, you should always suspect. First thing you need to suspect is lupus nephritis. So lupus nephritis is one thing that can present at this is there that can present as minimal. There is different classification of lupus nephritis. I'll discuss later on. Minimal mesangial proliferative, focal proliferative, diffuse proliferative. There are many classifications that can present in varied presentation. What kind of nephropathy is there? Let's say mesangial proliferative is there. You'd only find only nephritic range proteinuria with mild hematuria like. So glomerular hematuria like pattern. Whereas the patient has membranous nephropathy. Class 5 of lupus nephritis present as membranous nephropathy, where you can find nephrotic range proteinuria. So always lupus nephritis need not be nephritic range proteinuria. Sometimes if there is a nephrotic class 5 nephropathy is there, class 5 lupus nephritis is there, where membranous nephropathy, you can present with nephrotic range proteinuria also. So that's why there is no hard fast rule. Only this should present a nephritic and nephrotic. It's a continuum. Nephritic and nephrotic are continuum like picture. So this might be a case of lupus nephritis. So there are other rheumatologic conditions also. There are rheumatoid arthritis, many other conditions, rheumatoid arthritis and Sjogren's, scleroderma. Rheumatoid and Sjogren's can present with nephrotic range syndrome, nephrotic where the membranous nephropathy is the cause. So you should always look at the various rheumatological conditions where they are presenting with different, where they can present with the proteinuria. Always look for some CTD related, what is the cause. Based on that, you can do a biopsy, you'll understand what is the pathology and then treat on that based on that. A 15-year-old female present with complaint of pain in the abdomen and present with hematuria and an evaluation has RBC cause and proteinuria. So this is a case of 15-year-old female. So this is a case of abdominal pain and present with hematuria. First thing you need to think of hematuria is any vascular causes present. Like hematuria, if a case comes to you in a renal OPD with a complaint of hematuria, first you think is vascular. Any renal vein thrombosis is there, or any microemboli are there. Like in the case of some case of atypical HUS or scleroderma renal crisis is also microangiopathic hemolytic anemia that can present with hematuria or mild proteinuria. Generally, any vascular cause is there. No, hematuria is more significant when compared to proteinuria. So hematuria is there. First thing you think about any vascular cause, renal vein thrombosis or any artery microangiopathic hemolytic anemia. That can be atypical HUS or that can be TTP, that can be scleroderma renal crisis, anything. So in all of those conditions, first thing you need to think. But this patient presented with pain abdomen, one thing, and also if you ask them history, you need to check a rash on the buttock. That is a classic case of Henon-Schleiner purpura, that is IgA nephropathy. So this might be a case of Henon-Schleiner purpura where presenting as IgA nephropathy. So what is the significance of RBC cause? Generally, what you see is when you're finding RBC in the urine, you need to check whether their dysmorphic RBC or cast is present. So anything more than 40% dysmorphic RBC or 5% acanthocyte or one single RBC cast is there also, that is glomerular cause of hematuria. That is why casts are only formed in the after glomerula is formed. So in other causes generally you don't find casts. So anything more than 40% dysmorphic or 5% acanthocyte or one single RBC cast is present also, that is glomerular hematuria. So this might be a case of IgA nephropathy. So generally most of the IgA, I'll discuss each brief case of IgA, what is membranous different, but this is to give how to evaluate, not to how to treat, but we'll tell how they present and all later when you discuss systemic topics. But this is how the case. This might be a case of IgA nephropathy first time presentation with pain abdomen. Always Henon-Schleiner purpura classical presentation is always abdominal pain. Generally they will have abdominal complaints, they will have generally rash. That is abdominal rash, that is the presentation. Generally kidney is unlikely to be known unless they are little elderly. Adolescents generally present with kidney failure. Generally younger patient doesn't present with kidney failure. And kidney failure is one of the adverse prognostic factor. A 60-year-old female with proteinuria and edema has history of constipation and melema. So as already told, a 60-year-old female, she has proteinuria and edema, so she has nephrotic syndrome like present. So this is a history of constipation and melena. always in elderly patient, whenever that patient is coming with one thing, you need to get present with proteinuria. One thing, if ask for comorbidities, any comorbidities is there. So diabetes or some amyloidosis is there, some like diabetes is there. Diabetes always low DKD related picture. Generally DKD can present nephrotic syndrome, but generally they have edema and hypertension associated. Also long-standing diabetes is there. They have associated diabetic retinopathy changes also, and also kidneys are generally not shrunken in diabetic kidney disease. And also amyloidosis. In amyloidosis, you will find renal failure. Some in male shift, you might find carpal tunnel syndrome, or also you can get a fat pad biopsy and check for any amyloidosis is there or not. So that is one more thing. Generally, this patient, that is how you evaluate. That is the different various possibilities in this case. And one more thing you can look for is since the patient is complaining constipation and melena, so there is proteinuria also. So since you're not finding any cause, you go ahead and do biopsy. If diabetes is not there, amyloidosis is not, you go ahead and do biopsy. On biopsy, you find to have membranous nephropathy. So what is the cause of membranous nephropathy in this case? What is a membranous nephropathy? There is primary variant called PLA2R variant and thrombospondin 7A variant, but that is primary membranous nephropathy. But before labeling any primary FSGS or primary membranous nephropathy, you need to note the secondary causes. So this patient is complaining of constipation and melena. You get a colonoscopy done where in this case we found a malignancy. So colon cancer can present with membranous nephropathy. So that colon cancer can present with membranous nephropathy. This is a case of colon cancer where the kidney involvement is due to the membranous nephropathy that's presenting a nephrotic range proteinuria. So this is one more case I want to tell you. So a 30-year-old female presented to OPD with proteinuria of 3.9 grams per 24 hours and with no complaints. So how do you go about this? Is classically a nephrotic range proteinuria, unlike previous case where the nephrotic range and fever joint pains are there. So then she landed up directly with 3.9 grams per patient with no complaints. So always when the directly present nephrotic range proteinuria, so you need to load, like I told you, FSGS is a possibility. You need to get a biopsy. So any proteinuria which is persistent for long time, especially nephrotic, you need to get a renal biopsy done. This might be a case of, since there is no nephrotic syndrome process, secondary FSGS is a possibility. Maybe she donated a kidney or some underlying condition like sickle cell disease or something is present, or you are finding you'll find some vesicular, some other cause might be a secondary FSGS. Generally, secondary FSGS is present with nephrotic range proteinuria than nephrotic syndrome per se. So now you go ahead and do biopsy where you find you might find this. In this case, we found secondary FSGS. Secondary to vesicular reflux. Patient has chronic reflux that is causing one kidney atrophy and the other kidney because of excessive pressure intraglomerular patient. The patient went to focal segmental glomerular sclerosis. So in that there is no immunostaining, there is no immune complex or anything. That there is only FSGS changes on the electron microscope. That is why secondary MSG is a possibility. A 30-year-old male present known case of celiac disease and has history of low back pain, now present with hematuria and an evaluation as nephritic range proteinuria. So this is a 30-year-old male presented with the complaints of celiac disease. So these long-standing rheumatological conditions also will have some amount of kidney involvement. SLE will have lupus nephritis that can vary from the mesangial proliferative to membranous nephropathy. Scleroderma can cause scleroderma can present with renal crisis where there will have hypertension as a presentation because of the vascular involvement, where you give AC inhibitors. You don't go steroids in that case. You give AC inhibitors as a treatment where the patient with hypertension and hematuria is a presentation. Whereas in the case of rheumatoid arthritis and Sjogren's, you might find Sjogren's can cause CTAD also. Rheumatoid arthritis, you find membranous nephropathy. So in the case of chronic say celiac disease and especially intestinal and this is spondyloarthritis, especially ankylosing spondylitis, and low back pain is one thing that suggests a low ankylosing spondylitis. In these cases, you will find IgA nephropathy is a common, especially in the case of any chronic liver disease secondary to alcohol, or some intestinal causes like celiac disease or inflammatory bowel disease or some ankylosing spondylitis. In them, you generally find the cause in the kidney biopsy as a IgA nephropathy, especially in alcoholics also. Because why it is the basic pathology is IgA is mostly secreted in the intestine is one thing, and also this IgA multimers are not degraded properly, and they form this and whatever complex multimers are formed, they are not degraded properly in the liver. So any liver pathology is there, that is due to the alcoholism or any chronic liver disease. So the IgA is not degraded properly, that forms autoantibodies against, and they form the antiglycan complex, and that they get deposited in the kidney, that forms the IgA nephropathy. That is the reason related liver. And also intestine and any intestinal pathology, any celiac disease or inflammatory bodies, IgA is hyper secreted, so they can also stimulate autoantibodies and they form immune complex and they get secreted and IgA nephropathy. So similar pathology is also found in ankylosing spondylitis and any spondyloarthropathies like psoriatic or arthropathies where IgA is excessively produced. So in all of these cases, spondyloarthropathies and intestinal cause of celiac or any Whipple's or some inflammatory bowel disease or any chronic liver disease secondary to alcohol, so you should always suspect IgA nephropathy is a possibility in all of these cases. So this is a case of IgA nephropathy we have seen. and this is one such case. And also generally the patients who are having chronic, especially the familial, these patients who are having familial Mediterranean fever, so or familial, some patients will have recurrent fever, pleuritis and joint pains long term. So long term fever, joint pains, there is a chronic inflammation also. The serum amyloid A also can deposit and can develop amyloid nephropathy also. So this is one case we have seen in the case of ankylosing spondylitis, where serum amyloid A is also hyper secreted. The amyloid A, they can classically present with nephrotic range proteinuria. So that amyloid nephropathy is also a possibility in the case of spondyloarthropathy if they are long standing. If you don't control the inflammation, any chronic inflammatory state will increase the serum amyloid. That can be rheumatoid arthritis, that can be spondyloarthropathy, that can be any inflammatory condition per se. It can increase the serum amyloid and can produce amyloid nephropathy in them, where you will find nephrotic range proteinuria generally. So we have seen one case, ankylosing spondylitis, long term 7 years, he is not on any treatment, he presented with nephrotic range proteinuria. We found amyloid nephropathy in them, serum amyloid nephropathy in them. So that is an so that is one possibility also. So these are the different possibilities you need to look at when there is a proteinuria. So a 22-year-old female, history of sore throat, now present with hypertension and hematuria. So this is a case of post-streptococcal glomerulonephritis. By this time you can look at it. So generally this is a transient condition. There are 2 or 3 conditions where you need not do biopsy in the case of proteinuria. Especially one is PSG and other is minimal change disease. And also other physiological causes. Other cases you generally go ahead and do biopsy. This PSG and MCD are generally, we don't require biopsy. They are transient. They can generally C3 is transiently, it will recover on its own. So this is one condition where you don't do biopsy. So this is a condition, 22-year-old female, after that PSG and after generally seen after Skinner and pharyngitis, we generally see the post-streptococcal glomerulonephritis. So generally transient low C3 is there. What are the condition where transient low C3 is there is one question. Generally that will be helpful in evaluation. One is PSGN, the other is SLE. You will find it in infective endocarditis also. Other causes also you need to look at. So you find out these causes, what are the causes where the proteinuria is there, low C3 is there, where proteinuria is there, C3 is normal. So these will help you in delimiting what are the causes so that you can work up better. So read about it and let me know. I'll comment it anyways later, but this is a condition where this PSGN is a possibility. It's a transient condition, it resolves and mostly occurs secondary to skin infection, but it can also occur in the secondary to pharyngitis. It's a transient condition, it will recover. But once PSGN occurred, if the same episode occurred again 3 years after this, let's say the same female after 25 years present with same sore throat and hypertension and hematuria, generally it will not occur again. Generally if the second time the same, if you're second time you should not suspect PSGN. So you need to get a biopsy done. What is the cause of nephritic syndrome? You need to suspect that might be lupus nephritis or some presentation of some C3 nephritis, same C3 MPGN or something, messenger proliferative glomerulonephritis, that whatever it is, biopsy will tell you what it is. But generally only first time presentation we take at PSGN. Generally they won't go for second time, no recurrences will occur. Generally if it is recurring again, you need to get a biopsy and discover if there is any other pathology involved in the kidney. So this is a PSGN as a positive. So there is one more condition called IRGN. So generally I will give an example. A 60-year-old female present with cellulitis, where on isolated found MRSA, but she has AKI on presentation where there is a proteinuria also. So that is a case of infection-related glomerulonephritis where the condition occurs parallel to the disease, generally associated with some significant comorbidity like diabetes and generally associated with MRSA infections. So this is a case of infection-related diabetes, infection-related glomerulonephritis where it occurs parallelly, especially in immunocompromised diabetes and some MRSA infection where you give antibiotic coverage along with dialysis. Generally they require dialysis also. PSGN people doesn't require dialysis. It is a transient condition that require only hypertension management is all what we require in the case of PSGN cases. So in IRGN you require dialysis, sometimes vancomycin, sometimes they require immunosuppression also. So that is the case of IRGN and PSGN differentiation. A 30-year-old case of HIV has oliguria and an evaluation have creatinine and elevated creatinine and proteinuria. So the HIV can also cause. HIV is one more cause that can cause FSGS. So HIV, anyone present with proteinuria, so you need to look for you need to get a renal biopsy also where you find collapsing kind of FSGS, which is a worst prognosis. So collapsing FSGS is a possibility in the case of HIV. HIV can cause proteinuria where you can need to there is HIVAN and HIVIC. So HIV associated nephropathy, HIV associated chronic kidney disease. There are two possibilities really about HIVAN and HIVIC. So this HIVAN is a case of collapsing FSGS. So that is a possibility where you give ART and initiate the ART. That is a HIV associated nephropathy. Because of the high viral load you get HIV associated nephropathy. That is a collapsing FSGS and that needs to unititrate the primary HIV with the primary ART therapy. Maybe it will subside. So generally that is the case. Collapsing FSGS is a possibility which is HIV associated nephropathy. This is a case of HIV associated nephropathy. So these are the various interpretation findings. After discussing all these cases, we'll go into the what are the different causes. So these are the various factors that will be helpful in diagnosis in the proteinuria case. Any fatty cast or any oil bodies nephrotic syndrome is a possibility. Any leukocytes, especially in the case of any urinary tract infection or any case of interstitial nephritis. Interstitial nephritis. Let's say patient was recently started on some rifampicin or some omeprazole. Patient has a like no oliguria is there, that let's say patient urine output is normal, patient has proteinuria, then the only mild proteinuria, that might be acute interstitial nephritis also. Sometimes in AKS and ATIDs, acute tubular interstitial disease, you find some mild amount of proteinuria, not significant proteinuria in the case like not more than 800 or 1 gram, generally around 500, 600 or 400, sometimes it varies. Generally albumin is not secreted, mostly non-albumin proteins are secreted, sometimes only 300 is there. They can be acute tubular interstitial nephritis also. In them you will find some WBC cast or some eosinophils might be there. Generally leukocyte WBC cast will be there. So that is a case of acute tubular interstitial nephritis. So always ATID can be related to some drug or some infection. Some drugs like you will find it in rifampicin, you will find it PPIs. So there are many drugs that can cause ATID. So ATID also positive, where you won't find significant proteinuria per se. Only milder proteinuria is there, and also there are more of renal failure, more of creatinine elevation. So that is a possibility. You won't find any significant hematuria or something like that. So generally ATID you will find other features like you will find it sometimes there is some electrolyte loss, there is electrolyte variation in the serum and urine electrolytes will be lost. Some isostheneria can be sometimes in the case of acute tubular interstitial where urine osmolarity and serum osmolarity are almost same. So concentration will be affected. You will find those are the markers that will tell you ATID is a possibility when there is a proteinuria. So normal shaped erythrocytes. Generally erythrocytes are normal shaped. That means that your RBC are directly excrete, that means urinary bladder. They are the most common cause of hematuria is generally from the bladder. 90% cause of hematuria are mostly bladder, only 10% are renal. So if there are dysmorphic RBC, generally upper, that will be kidney or something. Dysmorphic RBC something, because when they are going to urethra or some tubule, connected tubule, they can become dysmorphic. So dysmorphic RBC, that is something upper respiratory tract. So if this there is RBC cause, definitely that is a glomerular lesion. RBC cause are generally formed in loop of Henle. So that's why it needs to be glomerular. Dysmorphic RBC cast is suggestive of glomerular, where a dysmorphic RBC can be anywhere in the kidney. But generally if you are finding frank RBC per se, that is generally bladder. Most of the cause of hematuria are generally bladder related. So erythrocyte cast glomerular, any vaccine cast chronic kidney disease, eosinophilia suggests of drug induced interstitial. This one more fact. Interstitial nephritis always eosinophilia is there, leukocyte cast will be there, some significant disease or some drug use like rifampicin or something, NSAIDs or some PPAs, that might be a cause, and you will find isostheneria, some electrolyte loss, urine electrolyte loss will be there, and also serum electrolyte variation will be there. So that will be suggestive of acute interstitial. Generally reversible if you after 2-3 weeks AK will resolve and you won't find any proteinuria or not. Now is there. Hyaline cast generally due to dehydration and diuretic therapy. So these are the transient proteinurias, where fever, any fever, systemic fever that can cause transient proteinuria, stress, especially in the case of gym workers, extreme cold exposure, extreme cold weather also that can cause proteinuria, and some excessive sympathetic stimulation also can cause, like you have severe, like if you send right now the patient is having bronchospasm, you send a proteinuria, it will always be positive. So epinephrine, any sympathetic stimulation can also cause proteinuria, any emotional stress also can cause proteinuria, seizures also can proteinuria, any surgery, recent surgery. So all these causes needs to be ruled out. Before sending a proteinuria, you need to understand these can cause proteinuria also, like any stress, any fever, any urinary tract infection. Menorrhagia can also cause sometimes proteinuria, like false proteinuria, RBC cause will be positive. So any sympathetic stimulation, these all needs to be looked into before going for pathological evaluation. So orthostatic proteinuria, this is one more important thing. Sometimes they'll have proteinuria in the morning and the proteinuria won't be there in the proteinuria in the evening, proteinuria won't be there in the morning. So the orthostatic proteinuria is one more cause, where you give 3 repeated morning samples will have normal protein, but if you check in the evening there will be proteinuria. So generally this proteinuria will be less than 1 gram, around 600-400 proteinuria will be, but morning samples will be normal. This is due to the orthostatic proteinuria, that is a benign variant. So that is a possibility. So orthostatic proteinuria you evaluate by, if you send it in the morning and evening, morning there won't be proteinuria, evening the proteinuria will be there. You send it for 3 consecutive, that will be orthostatic proteinuria. So sometimes thin basement membrane disease also can cause proteinuria. So other causes are minimal change disease, because FSGS is a possibility. Post-infectious membranous can be possible. Lupus nephritis, HSP we discussed, HIV we discussed. So lupus nephritis we discussed. Vasculitis can be a cause. Vasculitis can cause both vascular related and also can cause nephrotic syndrome like picture. Any hydronephrosis or cystic disease or reflex nephropathy, they can cause FSGS like picture and can cause proteinuria. So these are the various causes of proteinuria per se. One thing, orthostatic proteinuria generally seen less than 25-24 years. So generally more than 10 years and generally less than 20 years. Creatinine will be normal, albumin will be normal, and C3 will be normal in them. So generally albumin excretion protein will be less than 1 gram. So generally more than 10 to 20. In adults and age will be generally not more than 30 or something. Generally first time presentation will be generally 10 to 20 or something. Nephrotic syndrome, edema less than 60, always MCD is a possibility. Creatinine will be normal in the case of minimal change disease. Generally low albumin, C3 will be normal. And protein creatinine more than nephron, more than 3.5 generally in the nephrotic range proteinuria, high cholesterol will be there. Acute glomerulonephritis, gross hematuria is there, creatinine will be elevated. Generally nephrotic syndrome, creatinine won't be elevated, MCD. So if nephrotic syndrome is there, creatinine will be elevated, blood pressure will be elevated, albumin will be low or normal, C3 will be low, especially in the case of post-streptococcal glomerulonephritis, transient low. Generally nephritic, not more than 3 grams, generally around 1.2 or something will be there. Hypertension, ASO, generally anti-dsDNA is more significant, ASO titer can also be done. FSGS and nephrotic syndrome, FSGS and membranous glomerular, FSGS in the case of especially 20 to 40, any elderly membranous glomerular nephropathy is a possibility. They can present as nephrotic syndrome or nephritic syndrome. It is a continuum. So generally hematuria, hypertension is generally we see because of the chronic nature. So creatinine will be high or low or normal. So generally nephrotic syndrome, generally because glomerulus is and all, that doesn't mean creatinine should be high. So generally they have only proteinuria as a presentation. You need to evaluate them also, even though creatinine is normal, because proteinuria itself is a significant marker. So C3 will be normal in the case of FSGS and membranous glomerular nephropathy. Generally protein creatinine ratio will be more. So MPGN is also a possibility. Messenger proliferative is generally present as glomerular nephritis more. Nephritic syndrome is more. Hematuria, hypertension is more. Generally C3 is low in these cases in the case of messenger proliferative. Lupus nephritis, rash and arthritis, HSP, generally hematuria, abdominal pain will be there. Generally C3 will be normal in this case. P3 will be generally known in the case of messenger proliferative, lupus nephritis, post-streptococcal and infective endocarditis, all those causes. Tubular interstitial polyuria will be there. Creatinine will be normal, albumin will be normal, C3 will be normal, all will be normal. Generally proteinuria will be less than 1. So these are all the causes, the common causes where you see proteinuria. So these are the various causes: nephritic syndrome, post-streptococcal, bacterial endocarditis, lupus nephritis, ANCA vasculitis can present as nephritic syndrome, Hanostena purpura, cryoglobulinemia, these can all. Pulmonary renal syndromes can also present with proteinuria, like good pasture syndrome. These are all biopsy diagnosis. You can't tell this is a case of, based on symptomatology you can tell, especially if there is bacterial endocarditis, you can tell subacute bacteria. And one more example you give after some time, like I give an example where the patient underwent a PTCA, now present with renal failure associated with proteinuria. That is a case of cholesterol embolus related proteinuria. That is also a possibility. Or immediately after, like in some case of DVT or something, after you start heparin or something, because of the that lysis whatever is happening, that time cholesterol emboli can lodge into the kidney. That is cholesterol emboli related AK or kidney, that can cause proteinuria, eosinophiluria and all. So that is also a possibility. So ANCA related, Hanostena purpura, abdominal pain is a possibility. Cryoglobulinemia is associated with HCV or something. Good pasture, both kidney and renal are involved. These are pulmonary renal syndrome. These are very important, where both kidney and renal are involved. Good pasture syndrome is one. ANCA vasculitis, where vaginals, where kidney and lung are involved. Microscopic palangitis, where you can find hematuria, like diffuse alveolar hemorrhage associated with rapidly progressive renal failure. Chalk stress is also a possibility, where you find eosinophilic lung disease associated with kidney involvement. Hanostena purpura, nephrotic, as I said, MCD, focal segmental membranous nephropathy, amyloidosis, all these are possibility. Basement membrane disease also can present with milder proteinuria, and hematuria is more significant in them, like Alport syndrome, thin basement membrane syndrome, antiglomerular basement syndrome, nail patella syndrome. These are all very rare, but you need to know the causes. But mainly remember this nephrotic syndrome, and these nephritic syndromes mainly where PSGN, bacterial endocarditis, lupus nephritis, IgA nephropathy, especially in the case of most IgA nephropathy is very common in India. Any patient present with hypertension, hematuria, always suspect IgA nephropathy. IgA nephropathy is one of the very common conditions in our setup, where hypertension and microscopic hematuria or some hematuria will be there. So always evaluate them for IgA nephropathy. And especially in the case of any celiac or intestinal cause, or there are some chronic liver disease also, any spondyloarthritis also, IgA nephropathy is a possibility. And this nephrotic syndrome, these are the causes. So these vascular causes, as I told, atherosclerotic nephropathy, hypertension, cholesterol emboli, as I said, after some PTC or some procedure or some after starting heparin, they can develop cholesterol emboli. Thrombotic Apla syndrome, these are all scleroderma renal crisis, these are all mentioned. More of hematuria will be there rather than proteinuria. Hematuria with hypertension will be there more than proteinuria. So post-streptococcal, subacute bacterial HIV, these are all we discussed. These are the various causes where we can proteinuria as a possibility. So FSGS, primary FSGS, where they classically present as nephrotic syndrome. Secondary FSGS mostly present with nephrotic range proteinuria. They don't frankly present as nephrotic syndrome. And primary FSGS will have immune complex deposition. Generally, these don't have any immunoglobulin deposition per se. Causes are hepatitis B is a possibility, and hypertensive nephropathy, reflex nephropathy. Wherever there is anatomical damage to kidney, FSGS is a cause. Like hypertensive nephropathy, reflex nephropathy, one kidney is damaged. Cholesterol emboli is a possibility. Any sickle cell disease, radiation nephritis, these are all NPH congenital NPHS1 and nephrin podocin mutation, actin 4 mutation. These are all cause of FSGS only. Heroin, analgesics, bisphosphonates. These are all cause. These are all the causes. Mainly you need to remember HIV is one cause, hypertension, reflex nephropathy, obesity, sickle cell, all these possibilities, and these congenital FSGS like syndromes. So membranous nephropathy primary is due to the PLA2R phospholipid A2R repeat mutation and thrombospondence. Secondary can be due to hepatitis B, hepatitis C, malaria, schistosomiasis, leprosy, or cancer. Solid cancers are all causes of any cancer is there. Membranous nephropathy should be a suspicion. Drugs like gold, mercury, penicillin, MS, NSAIDs can be good. Autoimmune SLE can present. SLE mostly MPGN, but for class 5 present as lupus nephritis, membranous rheumatoid arthritis, primary biliary cirrhosis, Sjogren's, Hashimoto's thyroiditis. These are all myasthenia gravis. They can all present as membranous glomerulonephritis. Other systemic like Fanconi, sickle cell, diabetes. So this just doesn't mean lupus nephritis can present with membranous only. So based on renal biopsy only we can tell what is the pathology. So SLE can present as MPGN, can present as membranous nephropathy. But these both are possibilities. Only biopsy findings will tell you what kind of pathology is there in them. So this sarcoidosis is a possibility. These are all possibilities of IgG4 is one cause that can cause membranous nephropathy. IgG4, rheumatoid arthritis, and PBC and Sjogren's are the conditions that can cause membranous nephropathy. So this is a classification where minimal mesangial, mesangial proliferative, focal nephritis, diffuse nephritis. These are all MPGN, mostly MPGN where subendothelial immune complex are there. Membranous nephritis is one thing where subepithelial. Generally membranous is subepithelial. Anything proliferative you will find it in vascular, so subendothelial. So that is MPGN is there, and class 4 till is membranous mesangial proliferative. This is class 5 is membranous where you will find subepithelial deposits. So sclerotic is class 6. So these are messenger proliferative. You will find it in subacute bacterial endocarditis, infective endocarditis, hepatitis C. You will find it in malaria, especially plasmodium malaria is one cause. Autoimmune condition is SLE, cryoglobulinemia is cause. So these are all the causes like multiple myeloma. Any monoclonal gammopathy also you will find nephrotic syndrome. But in multiple myeloma it is mostly overflow proteinuria, because excessive protein generation, overflow proteinuria will be there. That can cause MPGN also. But these are all the causes. Mostly hepatitis C is a cause, cryoglobulinemia is a cause, SLE is a cause, infective endocarditis is a cause, and malaria is a cause. So these are all the causes of MPGN. So there are various causes of MPGN. There is C3 glomerulopathy and MPGN. I'll tell you about this later when I'm discussing about MPGN. So that is the end of presentation. Thank you. So like I said, always look into the physiological causes when you are looking before sending a proteinuria evaluation. Always this transient causes needs to be low. So when there is significant proteinuria, always look out orthostatic proteinuria is there, or some physiological cause of proteinuria is there. So heart failure can also cause proteinuria. So after that only you need to get a sent from the renal biopsy, and you need to check the C3 levels. Sometimes C3 levels will be low in the case of infective endocarditis. Some lupus will be there, some post-streptococcal causes. So in them MPGNs C3 will be low. Some conditions C3 will be normal. Tell me what are the causes where C3 will be low and C3 will be normal, and get a renal biopsy done. And there might be secondary cause, so always look for the secondary cause also. MCD, Hodgkin's lymphoma, or some allergy history there, some NSAID history will be there, FSGS, some reflex nephropathy, some obesity, some sickle cell disease, some HIV, or some congenital conditions. These all needs to be looked at. Membranous, any solid malignancies are there, hepatitis B is there. So any rheumatoid arthritis or Sjogren's disease, primary biliary cirrhosis, that is a possibility. Whereas in the case of MPGNs, you look for malaria, you look for infective endocarditis, you look for any SLE is there. So these are all the various possibilities you need to look into the cases. So always look for just because proteinuria is there, if there is hematuria, always look for IgA nephropathy is there or not. In the case some procedure, cholesterol emboli can also present as hematuria. Sometimes purely present as hematuria, like renal vein thrombosis or scleroderma renal crisis, where there won't be significant proteinuria. Those vascular causes also will need to be. Generally vascular causes will generally present more of hematuria when compared to proteinuria. So these are all the points you need to remember while you are evaluating for proteinuria.